This is my presentation on an inflammatory abdominal aortic aneurysm. The patient is a 65-year-old Caucasian male. He has a history of smoking from the age of 20 to about the age of 50. He also has a family history of AAA. His father in particular had a AAA, and this patient was previously diagnosed with atherosclerosis. His lab values showed high levels of protease, an elevated C-reactive protein, and elevated white blood cells. These values are all indicative of a weakening of the aortic wall. The symptoms that this patient had were back pain and epigastric pain. However, other symptoms can be chest pain, pulsatile mass, hematuria, and gastrointestinal bleeding. Imaging findings for this patient: there was dilatation in the distal abdominal aorta, atherosclerosis in the posterior wall, and the radiologist noted a bilobed aneurysm, and it measured at 7 centimeters in length and 4 centimeters AP. This image just shows some normal anatomy, what a normal abdominal aorta should look like, how big it is. For the pathology, this image shows the mid-aorta. It's partially obscured in this image, and it shows atherosclerosis in the posterior wall. And then in this image, you can see an enlarged distal lumen at 4 centimeters AP and atherosclerosis seen clearly in the distal wall. The incidence for AAA, average age of diagnosis is 66 years old. Inflammatory aneurysms account for about 5 to 10% of those. The incidence of AAA in the general population is 5 to 7%, but if you have a family history, that quadruples. If it's an immediate family member, that goes up 12-fold. And then a rupture AAA has about a 50 to 80% mortality rate, depending on the literature you read. The causes for AAA can be atherosclerosis, inflammation, infection, connective tissue disorder, or congenital abnormalities. Some risks to develop it: about 8% of males over 60 years are at risk. If they're a smoker, if they have a family history, they're Caucasian, have hypertension, or hypercholesterolemia. The physiology of this disease: atherosclerotic plaque can build up and cause inflammation. Connective tissues then are broken down, which weakens the aortic wall, and then there are reduced nutrients and oxygen levels. That's due to the decreased diffusion because the wall is so thick, and then this causes cell apoptosis. The course of the disease: inflammatory AAA is characterized by activation of T cells due to inflammation of the aortic wall. The vessel wall breaks down and that thins due to inflammation, degrading the elastin and collagen. Hypertension then causes stress on that already weakened wall, and then the collagen fibers can no longer resist the tension and they burst, causing that aneurysm. Some treatment procedures for AAA. If it's over a certain size, immediate surgical intervention is recommended to avoid rupture. An endovascular abdominal aortic aneurysm repair is very common, and that's used in opposed to open surgery, just because there's shorter hospital stays, fewer complications, and greatly reduced recovery time. You can also take medications to reduce the growth rate of the AAA. Also, the patient should take medication for their high blood pressure, and the patient should stop smoking. The prognosis for somebody with AAA: if there's a screening, their prognosis is a lot better, and it can reduce the rate of ruptures. AAA's expanded at a rate of about 0.2 to 0.5 centimeters per year, and for every 1 centimeter increase in size, the rate of their rupture is predicted to double. A AAA over 5.5 centimeters usually indicates that there needs to be some kind of intervention, and if there's a rupture, there's definite intervention required because there's a 50% mortality rate when there's rupture. Some related information on AAAs. There's different types. There's bilobed. There's a multi-lobed, fusiform, which is it's kind of shaped like a spindle. It's all along the length of the wall, whereas with a saccular, it's kind of round and saccular shape, sticks off the wall. A pseudoaneurysm is a hole in the wall that leaks blood into the tissues. For the discussion, the frequent cause for inflammatory abdominal aortic aneurysm are atherosclerosis, and male smokers are at increased risk. All male patients should be screened between the ages of 65 to 75, and if they're smokers, that age is usually about 55 years old. If an aneurysm is seen, immediate intervention is not necessarily required, but the patient should quit smoking and take medications to improve their blood pressure, to avoid rupture, and hopefully reduce the AAA. And then some differential diagnoses are strangulated hernia, acute cholecystitis, acute pancreatitis, lymphoma, diverticular abscess, and ruptured viscus. And that includes my inflammatory AAA presentation.